So why kinematic alignment? Why change from the conventional? So the alignment, we are looking at coronal, joint line orientation and rotational. What about the ligaments in soft tissues? Do we need a different set of implants and instrument to go with? And what's the evidence that has convinced me to switch to this technique? So the outcomes of total knee, we can safely say that they last maybe 20 years with the conventional instrumentation, no arguments there. Now, when you look at the normal alignment, when you draw the mechanical axis, here shown going through the center of the knee, and it may not, irrespective of the position of your leg, that axis does not change. However, if you look at the joint line, depending on where the foot is, as in a stance phase, the joint line is medially sloping, and as when you walk with your feet together, then the joint line automatically becomes parallel. So the tibia is there in varus for a reason, so that you can get your joint line parallel when you're running or walking. Historically, we had the anatomical alignment proposed by Hungerford and Krakow, where they did cut the tibia in varus of 87 degrees and the joint was medially downsloping. However, they were still committed to the mechanical axis, and so the distal femur was cut in more valgus than the mechanical alignment. And we are all familiar with the mechanical alignment principles, but the joint line does slope laterally in this case. So why has, in the last 30 years, tibia has dominated our technique with these two laws? We cut at 90 degrees and minimize the thickness of the bone cuts. Now, why this rule? Because we have seen in the 1980s, with the earlier instrumentation, there was a lot of failure with 3 degrees of varus. And why minimal thickness cut? Because we've been told that if you go further and further deeper down in the tibia, the implant will sink and there is a risk of loosening. So the consequences of this cut is in the tibia, we'll cut more in extension and rather than in flexion. Laterally, we cut more on the tibial side, and therefore we have implications of that both in extension and in flexion, which demands a change in the femur, and thereby we under-resect laterally in extension, and therefore the soft tissue release and 3 degrees of rotation, which you're all familiar with. So these are all compensated because it leads to relatively tight flexion and extension gaps. And all this is factored in the implant. Now, if you look at the patient-reported outcomes, and these are large numbers from good centers, there's a dissatisfaction rate of 20 to 25%. And I suggest, could alignment be one of the reasons of this dissatisfaction? And I recognize these are multifactorial. Now, what are the assumptions of the conventional? Mechanical alignment is normal. Now, Eckhoff's series of CT scanograms show that only 2% show a mechanical axis around 0. The rest of them is plus or minus 3 degrees. And this is Insal's awardee paper in 2012 of Bellman's talking about the constitutional varus in the proximal tibia also. So again, we don't have mechanical axis going down the center in all. What about the rotational axis? The transepicondylar axis is the rotational axis is what we have been told. Again, Hollister's paper says, in combination with the ABJ's best paper by Eckhoff, saying that it is a cylindrical axis, and this axis goes through circles of the lateral and the medial condyle, and the transepicondylar axis is anterior and proximal to the cylindrical axis. So the suggestion is, and this is again from the Kinematic designers paper where you looked at MRI studies of 155 knees where they drew this circle on the largest diameter of the medial and the lateral condyle, and the center of the circle is where the tibia flexes and extends is what is proposed. So this concept, the cylindrical axis, is the green, which is the axis around which the tibia flexes and extends. The magenta colored one is the one where the patella flexes and extends. And the tibia rotates around in the line, yellow line, perpendicular to those two axes. And that's the axis around which the tibia rotates. Now, what about the assumptions of the design? Now, we have these multi-radius design. Now, if you look at the lateral and the femoral medial condyle, we know they have different radius of curvature. And therefore, we have these multi-radius J curves. What about a single radius implant? If you have that, then there is no mid-flexion instability as you would expect in a multi-radius implant. And so getting up from the chair, because there is no mid-flexion instability, is better. Now, if you look at a single radius implant versus a multi-radius implant, in a single radius, the center of the rotation is much posterior, so there was an advantage at the lever arm. Now, if you look at the two, the multi-radius one, the implant does jut up behind, and the quads is at a disadvantage. Balancing gap is good. We have technology to back us up, but do you really need equal extension and flexion gaps? And do the ligaments really contract in a standard varus and valgus knees? So the mechanical cut alignment technique introduces anatomical modification, and it creates imbalances, and you have to manage it with a soft tissue. I remember my teachers telling me that TKR is a soft tissue procedure, and you have to address the soft tissues to manage the implant. What about the natural gaps in the native knee? In extension, you don't need any play, but in flexion, the lateral side opens up as much as 3 millimeters on varus testing. This is another paper from Professor Freeman's university talking about the amount of rollback. So there is a medial pivot around which the femur rolls back, and you require a lateral ligament laxity so that you can get the rollback. This is another paper looking at the isometricity of the collateral ligaments, and we very clearly shown that the LCL is looser in flexion, allowing us to, when we bend, for that rollback. So yes, in full extension, you need a stable situation, but in a 90 degrees of flexion, you do need a little bit of laxity on the lateral side. So what if we are not aligning these knees correctly? What if the mechanical axis is not the right axis? The transapicondylar is not the axis around which the tibia flexes and extends, and that the gaps should not be balanced, and the femur should not be rotated 3 degrees. So these are the time to look at the new alignment techniques. So many modern cemented TKR seem to tolerate 3 degrees of varus, as has been shown by the Mayo paper, 20-year survival rate where the mechanical axis is beyond the 3 degrees outliers, and they have still stood the test of time. And tibia you can resect fairly deep without worrying about the consequences of loosening. So the kinematic concept is replace whatever you're resecting, factoring in the loss of cartilage, expecting a better functional outcome. Now, what is a cartilage thickness that you are replacing? 2 to 3 millimeters in a fully worn out bare bone situation. So in this technique, all that you need is a caliper, and you try and resect, measure, and replace whatever you're losing in the cartilage. Just a case example of a patient with an Oxford knee score of 17 and 20. This is the resection that we are going to plan. This is the bare bone, 2 millimeters of cartilage loss, distal femur resection. This is the only instrument at the moment that I can think of which allows me the distal resection planning independent of degree of the varus valgus. So I resect, the distal femur resection is done, measured. Medial side, the more worn side is 6 millimeter, lateral side is 8 millimeter, factoring in the saw blade and the cartilage loss, I get 9 millimeter distally. The posterior referencing is used without doing any internal rotation, and I get an equal resection, 8 millimeters. This is the Vanguard Biomet instrumentation that I use. And the tibia is cut in a little bit of varus. Now the tibia has to be cut to match the femur. So that's the amount of resection on the tibia is seen. It looks chunky, but when you look at the extension gap for a 10 millimeter, nothing, it's 0 varus valgus. On flexion, there is a 3 millimeter opening on the lateral side, tibial rotation matched. The anterior posterior offset jig is used to find out how much whether I've got that 2 millimeter distalization of the medial femoral condyle. This is a Sander preparation, implantation. And this is the work chart to show me that in spite of that chunky tibial removal, I have a 10 millimeter flexion and extension gap, and that's how the X-rays look. It may look like the tibia is in varus, but the correction is, when you look at the long leg films, it is not as alarming as you would initially, your first impression would look. That's how so I am not aiming for a varus knee. I am correcting whatever is lost, and whatever correction I get. That's what I'm kind of looking at. What is the evidence of kinematic TKR? Now, there are several series now which talk about functionally they do better than the mechanical alignment. There's one publication from Korea which talks about equivalent result. Otherwise, the kinematic groups are functionally doing well. What about single radius versus multiple radius implant? This is from the triathlon and Durocon. The single radius implants are functionally better. Well, how about the gait in a mechanical and a kinematic TKR versus the normal? So here are the two groups compared with healthy individuals and the gait analysis done. So the kinematic group matches more the control group than the mechanical alignment group as shown. What about two different implant design done by a mechanical alignment? So you have triathlon as well as a next gen. These are multi-radius implants, and their gait, if you see, is way away from the normal as shown in the green. So what about using this different alignment technique but the same implant? So here you have on the top triathlon and the next gen being used using the mechanical alignment, and the one in green is the graph for a normal gait. Whereas once you have changed and used a triathlon implant with a kinematic alignment, they come more and more matching the normal gait pattern. So the same implant has been used with different alignment technique, and the gait pattern is more closer to normal. So the clinical outcome shows that in kinematic alignment, the functional outcome is better, and the forgotten knee score is better. What about survival? If you're changing the alignment, do these last? Now, I recognize this is a 10-year paper from the original author. He's published the 6-year data as well as the 10-year data, and he has shown that there are 20% valgus outliers and 7% varus outliers. The survival is 98% at 10 years. So alignment itself may not be that much of a concern as much as maybe other factors like balancing and so on. So to summarize, TKR has some unsolved problem. The traditional alignment may be part of the problem. Kinematics alignment may be one of the solutions. It is not an evolutionary technique. It has been there as an anatomical alignment. It's a technique in evolution. And there are good reasons to reconsider the fundamental assumptions around what constitutes an appropriate alignment. It does produce a good short-term and mid-term results now. However, the tibial cut is a challenge, and we do not know if there is a maximum amount of varus that this will allow. There are many questions still to be, I recognize that, about kinematic alignment, and we do need to kind of look at these closely. The anatomical and mechanical alignment makes everyone the same, and I suggest kinematic alignment recognize each patient individually. And I also have my concerns. So then we are putting the normal tibial joint line is in varus, the normal femoral joint line is in valgus. We are kind of internally rotating to what you have been conventionally taught. And kinematic alignment forces us to place these components outside the accepted parameters of a normal TKR. I'd like to thank you for your attention.